Hey, this is Jake Worsham. I'm here with the University of Texas Orthopedics in Houston, sports medicine physician out in Sugar Land and Katy. We're going to be here presenting to you today common shoulder injuries for the Game Ready series. We're posting on Facebook. Anyways, overall, the goal of this talk is for us to be able to direct information to trainers, athletes, and the public in terms of common shoulder injuries, to where you guys can have an idea of how a physician perceives these, how to communicate with your team physician, and also for the athletes to understand the injuries a little bit better. So next slide, we'll take a look at the common shoulder injuries overview. This is kind of a layout of the talk. Really and truly understanding the bony anatomy, the ligaments, the muscles, and tendons of the shoulder gives you a better idea of when something does hurt, it can be affected to that area. So it'll give you an idea of regional pain. The next thing we're going to discuss is we're going to discuss fractures and injuries. We're going to start at the sternum with the SC joint and work all the way down to the elbow. I think that there are two exceptions here. I think Dr. Gregory and Dr. Ozude have already covered some areas of this. Dr. Gregory did a great job covering the shoulder, and Dr. Ozude covered shoulder dislocations and instability, so you will not see that in this talk. If you want to see information on them, please refer to their talks. I think they'll be posted to the website. And then the next we're going to talk about is rotator cuff and impingement. Not as common in young athletes, obviously, but affected in the community. Good to know the difference and kind of get an idea of what's going on. The next is shoulder overuse, which we see very commonly in young athletes. So it'll be good to talk about. And then also progressing into throwing injuries in children, which I believe Bony or Dr. Gregory covered explicitly. So talking about the bony landmarks, if you look up here on the right hand of the slide, we start with the collarbone or the clavicle, and that's you can feel that on yourself. That extends over into the AC joint. The AC joint is an area where the scapula and the collarbone connect. It's a normal joint in the shoulder. It allows us to have motion, typically overhead motion above the body. It can be an area of pain and issue, and we'll discuss that today. The next is the glenohumeral joint, and so that's your ball and socket joint. That's actually how the shoulder moves. So when you lift your arm up, that's that first 67% is that glenohumeral joint. It is more of a ball and plate, so a lot of people think of a ball and a socket. So ball, socket, it's more of a ball and a plate. And so there's a labrum that Dr. Ozude talked about covering that, which improves the stability of the joint. The rotator cuff also helps with that. And then the next is your humerus, and that's the big bone in your arm. The next section that we want to talk about and kind of understanding shoulder stability and motion, and also just the basic anatomy is the ligaments. If you look at the upper right of your screen, you can see the Clavicle ligaments, and those attach from the coracoid, which is right here in the front of the shoulder, and those keep your collarbone down. And we'll talk about those specifically in AC joint injuries. The other ligaments that are very important are the glenohumeral ligaments, and so they can have issues. And Dr. Ozude covered those in his dislocation talk, but they're good to know for general knowledge of the shoulder. The muscle and tendon anatomy, which we'll discuss today. So there are four major muscles of the rotator cuff, and they start in the front. So the front is the subscapularis, okay, and you can see that here to the very right of your screen. The next is there's a small interval in between the subscapularis and the next muscle where the bicep tendon runs in. Then after that, the supraspinatus, the infraspinatus, and then the teres minor. The subscapularis does a really good job of having you bring your arm in. The supraspinatus, helps you raise and elevate your arm. The infraspinatus and teres minor work on motion like this, so almost extending out. External rotation is a big fancy word for it. So that's kind of a brief overview of shoulder anatomy. I think we could spend a lot more time on it, but for this talk, I think it'll kind of get us to where we need to be. And if there's any questions, don't hesitate to ask. So starting with the sternum, this is the fractures section. We'll start from the sternum, go all the way down to the elbow. This is a sternoclavicular joint. So sternum and then clavicle, or your collarbone. These injuries can occur with a collision or a hard fall. I think that you can relate to maybe some NFL athletes. Tyreek Hill, when they played the Jacksonville Jaguars last fall, had one of these and was out for about 4 weeks. So there are two different ways that this can go. If you look at the slide on the right, you can see that patient's left clavicle is sticking out front. Okay, the sternoclavicular joint is dislocated anteriorly, and so anterior is forward, posterior is backwards. Okay, so that is easily identifiable. These can happen in acute trauma. It can also happen from infection and other disease processes, but in this talk, we'll stay with the traumatic injury. Usually happens when you fall directly on the shoulder, take direct trauma. In a posterior dislocation, which we'll talk in the next slide, the clavicle actually pushes back, and that's more of a concern for us. Children can also fracture this through a growth plate. It can be what we call kind of a fracture through the physis. Okay, so that's something we watch for as well. This is for game management and discussing, for the trainers discussing with their physicians. This is a diagnosis based on clinical suspicion. You'll find that there'll be tender in this area. Very alerting symptoms on the field are difficulty breathing and issues with dizziness and symptoms of lightheadedness. The big thing, if you look at the right hand of the screen, this is a CT scan looking at the shoulder. You'll see the arrow pointing to the end of the clavicle, and that end of the clavicle is actually pushing back when it goes posterior, and so it can actually cause the trachea or your windpipe to compress. It can also press on the blood vessels as well. So Rudy Lazar, who's a trainer at Pato, and I had one last year. And so he was very diligent and did a meticulous examination and found this out. We were able to get the patient the appropriate care they needed. Another thing for trainers is realizing that this injury is, I know this is a common shoulder talk, this is more of a rare injury, but it's something that you need to be aware of. And so to understand that not all facilities treat this injury. In the Houston area, I'd say the main treatment for this is typically in the medical center area. If it's in isolated where you don't have any of those symptoms, you don't have any issues breathing, any issues with lightheadedness or concern, most heal with these in sling immobilization. So we usually leave them out. It's very concerning once you destabilize that joint that it can go posterior. And so usually these kids sit out for an extended period of time to allow that capsule to heal. And only in the cases of late instability or continued instability do we go in and we actually reconstruct that joint. It's pretty rare. So these kids are monitored and they're watched. And I know we've had a few that it's a frustrating injury, but we watch it. I think, like I said, an NFL level athlete was out for about 4 weeks or 4 games. Kids, I think we're going to be a little bit more careful with it. So that's something you can discuss with your team physician. Clavicle fractures. So we'll move on, moving down the process. So clavicle, this is your collarbone. It's important for function, overhead movement. These typically happen with collisions or hard falls. I see them a lot in wide receivers and cornerbacks going to catch a ball. It's broken most commonly in the middle, as you see on that upper left-hand shot. And it also can be broken at the end or the middle of the bone. The most common is the middle, which is right about 80%, and then distal or the end of the bone is next. It's very important for overhead athletes. There's concern for overhead endurance or function if it doesn't heal properly. The main symptoms can be obviously pain, deformity, skin tinting, and then inability to lift arm. And so how we go about treating these, as a trainer, evaluating these with your team doctor and discussing these are important. Obviously, you need an x-ray to confirm the diagnosis. Sometimes you can have skin tinting, as you see in the bottom right-hand corner here, which can elucidate and kind of give you an idea. This is a clinical diagnosis, but it needs to be confirmed on x-ray to be appropriately addressed. So you can treat these non-operatively depending on the fracture. It's based on displacement, fracture type, patient's functionality, dominant arm, and the treatment's tailored to each individual patient. The most common way that we fix these is with a plate and screws. Non-operative management typically takes roughly 8 to 12 weeks depending on the patient. Starts with a pendulum exercise, which is where you hold your arm forward, lean over, and then move your arm below the level of the chest so you don't lift or aggravate that clavicle. It's important if you do use sling immobilization in any one of these upper extremity fractures is that we move the elbow. We also move the wrist to make sure they don't get stiff. And so, you know, based on the individual athlete, if you look at the upper right-hand side, that is still a skeleton mature athlete, but the amount of displacement and the fact that there is a kickstand fragment in between those means that we need to put those back into the same zip code for them to heal. And so typically when we have something that displaced or if the fracture's open, it's something that we'll go fix. So I typically use a dual plating construct for young athletes. I think it gets them back to where they need to be in that 8 to 12 week mark, depending on the patient. Onto the AC joint. So if you look at the AC joint, I think you've commonly heard this as a shoulder separation or injury. That joint can be dislocated. And so once again, using NFL athletes, I think if you remember the 2009 season with Sam Bradford, he popped his shoulder. Matthew Stafford's had this injury before. It's common when a quarterback or a player gets driven into the turf. And really the acromioclavicular joint is just a fancy way of saying where the collarbone and the shoulder blade meet. There's 3 grades. First is a sprain, typically doesn't move. If you look at the x-ray on the right-hand side, you can see that clavicle, that collarbone, doesn't line up with the acromion. And so that actually is a grade 3 when you have 100% displacement. When you have a grade 2, those are slightly elevated. And so there's different ways that we look at this based on what ligaments are torn, if you remember the anatomy and ligament slide. And so it's important to evaluate these with clinical diagnosis. It's usually a visual diagnosis, tender over the joint, unable to lift the arm, and painful on cross-body adduction, meaning that you move your arm across the body and when you press down, it makes that joint compress. So these are the 3 types right here. You can see on the upper right-hand corner. Type 1 typically is a strain of those joints that connect the collarbone and the scapula. The second is actually a tearing of those. And then the third that's where you get the elevation, and that's where you tear the clavicular ligaments, the conoid and the trapezoid. And so when those are torn, you usually have less stability. And you can see the clinical deformity there on this patient's right shoulder on the right side. Most grade 1s, grade 2s are treated non-operatively, very rare to have any surgery for that. Usually it's a sling for comfort, early range of motion, and then resuming normal activities when comfortable. It can be, depends on the patient, can be a 4 to 6 week injury, maybe longer. Surgical options are, the type 3s are a gray zone. Some do very well and heal on their own. Patients are asymptomatic, meaning they don't feel it. Other people continue to have clicking, popping, pain. And so that treatment option will be made by your physician in evaluating that individual patient. And that involves reconstructing those joints or acutely repairing them depending on the patient injury and timing. And so it's important for a trainer not only to identify this, but also to get with a team physician once again, working it up, making sure that we know which type it is and so it can heal successfully, and which ones need to be treated with surgical intervention. And as we're going along, please don't hesitate to ask questions. So proximal humerus fractures, this is can be injured. This is kind of a bimodal distribution. Big fancy word for this, happens in young people and old people. It's different in kids and adults. Children actually have a great healing rate for the proximal humerus. In the adults, it's a more difficult thing to heal. So in these, they're pretty rare. In kids on the field, this is more or less an injury as we get older. But you need to clinically evaluate the pain in the arm. You can confuse this with dislocation. That can also occur at the same time, where you have a fracture and a dislocation. But that'll be evaluated by your treating clinician. I think the key thing is to contact the team physician about the injury, make sure we get the radiographs, and then the appropriately advanced imaging study. Sometimes CT or MRI is needed. And so for these, the evaluation, the diagnostic exam is important. The pediatric patients do actually very well. There's a classification for these based on how much they displace. And so that's how we assess if they need to be treated with surgery or conservatively. If it's conservative management, typically it's a 8 to 12 week healing time with calcium and vitamin D treatment. You can see the sling over here on the right. Sometimes they'll use a weighted cast around the forearm to pull traction and gravity on that piece to get the shaft to line up with the proximal humerus. But overall, these do very well in pediatric patients as long as there's no soft tissue interposition, meaning that there's no the biceps tendon isn't in the fracture or things like that. The progressive passive range of motion overall does really well. And this can be a combination between the physician trainer and the physical therapist in terms of getting the patient back. Surgical options. So, if you take a look on the left of the screen, that's a pin. And so those two pins are placed to hold the fracture together in something that's a clear dislocation, or excuse me, not dislocation, but a clear fracture that's separated and there's displacement. Once those pins are placed, it allows the fracture to heal, and then they're pulled in the office. The middle one is a geriatric patient we fixed recently. That's a more aggressive treatment option, but involves really opening up the shoulder through an incision in front, putting a plate and screws on the humerus to where they have functional range of motion. And then if the fracture's very, very bad, typically in the elderly, you can see that on the very right-hand side, we have a reverse total shoulder, which I think we'll stay away from that in this talk, but just understanding the continuity of treatment. Majority of these in kids, non-operative. Even in fractures in the adults can be treated non-operatively, but we do have surgical solutions for people who continue to have pain and no function. All right, humeral shaft fracture. I think this is the last shaft. This is the last fracture portion. So this bone can be injured with a hard collision or fall. Sometimes these bones fracture and there isn't much trauma. Sometimes there can be things called pathologic fractures, where it's either benign or other tumor that can cause the bone to fracture with minimal trauma. So that's probably beyond the talk, but that's another reason why it's important for the trainers to get the patient to the team physician in the emergency room. So this has a great healing potential within the correct rotation alignment. Symptoms obviously are discomfort. Some patients will feel like the arm is detached, like they try to move their arm and it doesn't move with them, and that's because the bones aren't connecting. The humeral shaft fractures are treated initially with a coaptation splint. You can see that up there on the upper right-hand corner, and then transitioned into a brace to allow these to heal. Overall, a significant amount of these, as long as they're in the right rotation, heal very well. If you look at the bottom right corner, we also operate on these. Although it's more rare, it's important in open fractures, either loss of reduction or inappropriate rotation of the fracture, and then also, depending plus or minus nerve injury. The radial nerve is in this area. So it's important to know these and kind of have an idea. Rotator cuff tears, the next slide, are injuries that don't happen acutely in kids. This is more of can be a chronic injury or dislocation in the elderly, but it's something to monitor in not only your athletes, but also the general population. So the rotator cuff is 4 muscles in your shoulder that help lift and rotate the arm to stabilize the humerus within the joint. This injury can happen from a fall or dislocation. And the main symptoms of these are weakness, inability to elevate the arm, night pain, and overhead activities typically aggravate these. So clinical evaluation is very important here. This is obviously a muscle and a tendon, and so important evaluation of motor strength and functional range of motion is important. Advanced imaging studies are usually necessary to diagnose these. And so here on the the right-hand side, you can see this is an MRI with an arrow pointing to where the rotator cuff tear. There's your ball and socket joint, and you can see that rotator cuff retracted to the right side of the screen, showing that space. And there's a arthroscopic representation of it on the bottom right hand of your screen. You can see the rotator cuff tendon intact on the left, and then the rotator cuff tendon torn on the right. So the goals of the treatment are to relieve pain and restore function. Non-operative and operative treatment can be used to treat specific types of tears. So I think that whether it's oral anti-inflammatories, injection, rehabilitation can be effective for the rotator cuff. There are also those that need to be treated with surgery. And so the patient's surgical treatment involves repairing that tendon back down to the anatomic footprint of the humerus, and that's essential to restore motion in some patients. There are patients that do very well. with non-operative management. It all depends on the tear type, and it's important to talk to your physician about that. Rehab can take time. Most activities back between 4 to 6 months, and full recovery between 1 to 2 years. Shoulder impingement. This can mimic rotator cuff, although uncomfortable. It can actually, in chronic situations, can cause rotator cuff injuries based on raising your arm up and kind of hitting that bottom of the acromion. You can see that in the upper right-hand corner with the black arrow showing where that contact is made between the ball and the acromion or the scapula. The non-operative treatment typically includes very similar for the rotator cuff, physical therapy, anti-inflammatories, and injection, and that's the mainstay of treatment for this. There are some times where you have a bony morphology of the patient, big fancy word for saying that the patient's normal anatomy causes a problem. And if you look on the right-hand side of the screen, you can see there's different shapes of the acromion. Those type 3 in the bottom right-hand corner typically cause the most problem. It's almost like a hook acromion, which can really irritate the rotator cuff. And so it's important to notice that on x-ray examination. And surgical treatment of this typically includes debridement of the spur and removing inflamed bursa. So we also do a diagnostic scope at the same time to evaluate the rotator cuff and make sure it's there. This is typically, if there's no rotator cuff injury with it, it's a quicker recovery than just the pathology with the arthroscopy, if this is the isolated problem. All right, next slide. Pectoralis tendon ruptures. You will see this. This is not as common as some of the shoulder injuries, but it's common in athletes, especially young males who are looking to gain mass. And so it's important to monitor these. It's a powerful muscle over the front of the chest. You typically use this in bench press, incline, decline. It moves the shoulder across the chest. So it's a motion across the chest, an internal rotator. It attaches to the humerus, and it's usually found in young and active males. You can see up on the right side of the screen, if you notice on the patient's right-hand side, you notice how there's a missing portion there attaching to the humerus, and that's a chronic tear of the pec. And so you can just see how the deformity is present on the patient there clinically. So this is something that if you see this clinically, usually you have bogginess in the axilla. You usually have big swelling and ecchymosis or bruising over the front of the shoulder. And so it's important for a trainer or a clinician to get these to an orthopedic surgeon pretty quickly. They do very well when repaired early. When we repair them late, sometimes you can't just put them back down. Sometimes you have to reconstruct them or build a new tendon. And those typically don't do as functionally well as a acute repair. Typically takes 3 to 4 months to rehab. I think if you're in the Houston area, you've seen J.J. Watts had this injury, and Whitney Merciless has had this injury. So just to kind of know that those athletes do come back functionally well as long as they're seen and diagnosed early. So as a trainer, clinically evaluating them and identifying them is important. Shoulder injuries in the youth. Looking at these, this is a very common thing that happens in young kids, typically little league shoulder rotator cuff tendonitis. Once again, as we discussed in the rotator cuff portion of the talk, it's very unlikely to be a tear in a child. This is more or less a tendonitis or an issue with the growth plate. And so this typically involves pitch count. This is around your athletes where they're pitching or playing 12 months out of the year and continuing to irritate their problems. So shoulder overuse in the youth. You got to remember that the ligaments around your shoulder are about 5 times stronger than the growth plate. So until the bones fuse, the ligaments are actually stronger in terms of pull. When you pitch or when you throw, that motion in the shoulder, you can have rotational torque. So a big fancy term for it moves around. And that growth plate is cartilage. It's not bone yet. And so there is some give there, which allows it to move. This repetitive over time can wear on that growth plate and cause irritation and pain. And so if we take a look at x-rays of this, you can see this is typically a little league shoulder where it's a quote unquote fracture. It's not an acute fall or injury, but that growth plate widening and pain can cause irritation. So the treatment mainly is focused on rest and rehabilitation. We typically use a sling. Can be a 2 to 3 month recovery depending on the patient, but really shutting them down, slowing them down, and then bringing them back with a slow pitch count. So typically no throwing till they're asymptomatic. Anti-inflammatory medication, ibuprofen, Advil, as long as it's approved by your primary care doctor, your orthopedic surgeon. And then also, a mainstay in this is calcium and vitamin D for me. I think that those are very effective in healing this quote-unquote fracture. And then emphasis on strength and core exercises in terms of pitching motion mechanics, and having not only the coaches but the trainer involved with that. So that's important. One of the last things that are important to talk about in this slide are the spine issues. And so one thing about the shoulders, don't ever forget the cervical spine. And so when you're treating and evaluating these patients, on the field, make sure that if they have this pain or there's a problem, that you continue to monitor and evaluate them. And if you can't find anything in the shoulder wrong, make sure you look at the neck. Stingers, burners, football players will come off the field and say their arm's numb dead, and you'll be looking at the elbow and the wrist, which you should, but don't ever rule out the neck. I think that the cervical spine and the shoulder are so close together and share common pain symptoms. And so you need to be very attentive and listen to the patient's or athlete's history in terms of that. And so unlikely to have any acute fractures or injuries, but we did have one, Dr. Camarillo out in Katy and the Cypress area, took care of at the wrestling tournament and really helped the kid out. The trainers and the physician in that did a really good job. So just be aware, be monitoring it, and just keep in close touch with your physician. Don't ever forget the cervical spine. So here are my references. You can look up those online as well. The AOSSM and AOS have great information in terms of patient portal and also understanding sports injuries. I recommend you take a look at both those websites. It's where I got a lot of information from this talk, and also I think they do a very good job of instruction. Overall, thank you for your time. Thank you for watching. I think I can be a little long-winded sometimes. So reach out to your team physician or clinician if you have any questions. If you don't have somebody you can contact, or you're concerned about an injury or want some information, you can always reach out. That's my email if you need anything, or if you don't have a trainer, or we work with some great outreach trainers, both Bob Marley, Dave Wilkinson, out in the west and southwest area. And so if you have a problem or concern, either get in touch with them or get in touch with me. We're happy to take care of you, and really want the athletes just to do well and be safe. So shoot me an email if you need anything. And then a special thanks to all the trainers who help take care of our kids, especially the ones that I work with. They're great. They do an excellent job, and they really take their time to make sure everybody's safe. So I appreciate your time. I think I'll open the floor for questions if you need to have, or have any specific questions, be happy to answer them.